and faculty to come to the stage, and we were ready for the first section of this morning. I would like to invite here we already have the Dr. Sozo here already, and let's say Razina Khan. Dr. Razina Khan here. Dr. Raj here. And on the other, let's say Dr. Trayang, come to the stage. Dr. Trần Trayang. Dr. Hill, call Dr. Raj. Here already. Yeah. Dr. Let's see, Dr. Sozo, Dr. Wei Chun Huang. Dr. Wei Chun Huang already. Yes, good morning. Okay, so we still left two faculties. So Dr. Brian here already, and one more left, Dr. Trần Trayang. I have the information that the Dr. Doan is busy with his family at home, so very deep sorry about that. So I have to replace him for this section. Sorry, faculty, the other side. Okay, and we will start on time. I just gently remind that we have only 15 minutes for your presentation. So other than that, I think you're here. Oh, yeah, next to me. Okay, wrong room? Okay, Marina. Okay, so I think you help me to introduce the first one.
All right, thank you. Sorry, I was in the wrong room. So good morning, everyone. Nice to meet you all. Raj from Brunei. So STEMI and ACS. The first presentation is from Dr. Frankie Tam from Hong Kong. A lot of us know him. The last time I saw his presentation was on STEMI was in Singapore. Yes. One of the most fascinating cases I've seen. So I'm sure we can look forward to some very interesting complications and discussions. Yeah. Thank you.
Okay, so thanks for the introduction. So good morning, everyone. I'm Frankie Pham from Hong Kong. So thanks to the faculty for inviting me to be here, and congratulate Dr. Hong for organizing this very wonderful meeting. I'm sure to be one of the best meeting in Southeast Asia. So today I would like to start, with complications, right, in PPCI. So this is a PPCI session, and I would like to start for complications first. So, slides is not moving. Okay. All right, so STEMI PPCI. So we know that PPCI in STEMI is the most rewarding procedure in interventional cardiology. We save the patient's life immediately, and we improve their short and long-term outcome. But however, as in all interventional procedures, complications may happen. And these are the complications in PCI in general. So we have access site complications, systemic complications, or coronary complications. But there are some complications which may be more common in the PPCI setting. For example, for access site, because we may use large bore device or MCS, we are using very potent antibiotics, so there may be a high chance of bleeding, hematoma, fistula, or pseudoaneurysm. And on the other hand, because of the thrombotic myelin or thrombotic phenomenon, we may have more stroke or more coronary no reflow, abscess, or vessel closure. And another very important thing is that for STEMI patients, they are very unstable to start with, right? So they have hypertension, airway compromise, risk of arrhythmia, cardiac arrest. So they are prone to develop all these. And at the same time, because the patient is very ill, if the operator is not stable, right, the operator may get unstable, the mind, right? So it may also increase the chance of complications. So let me show you a case that may illustrate all these, right? So this is a 73-year-old lady, hypertension, rheumatoid arthritis, admitted for acute inferior STEMI, right? So on admission, she was stable. You can see blood pressure is okay, pulse okay, and you can see ST elevation in the inferior leads on the ECG. Right, so this is the angiogram. Okay, left side, some stenosis, the circumflex LAD, not very bad. Okay, again, cranial wheel, some stenosis here. And actually, there's a LAD CTO, right? But obviously, this is not the culprit at this time. So this is the culprit, right? Acute inferior STEMI, critical stenosis in the proximal to beat RCA, right? So we passed the wire, right? Still okay at that time, patient stable. And the operator decided to use some gentle ballooning and do an IFIS. So in the IFIS, you can see a lot of plaques, right? From here and here, you can see this a lot of attenuation, probably some calcium or some very lipidic plaque. So, and the operator used a bigger balloon, and this is usually what you will see, right? So the acute vessel closure of the RCA. So this is what usually happens. STEMI, balloon, okay? Patient, chest pain, ST elevation, shock, bradycardia, heart block. You can see complete heart block. We have to immediately put in a time pacing, right? And we use a lot of different drugs, right? So IV adrenaline, IC adrenaline, or adrenaline, everything. We just get it everything to get the patient stable, right? Okay, so very typical scenario: STEMI PPCI, ballooning or stenting, and then no flow, and the patient decompensate. So at that time, the operator decided to stent the RCA, right? But again, this leads to other complications. So the operator cannot deliver the stent to the RCA, and they pull it back. And this is the classical example of how we dislodge the stent. The stent proximal edge catch on the guiding catheter, and then dislodge in the proximal part, right? So at that time, no reflow, unstable patient, and stent dislodgement, right? So at that time, the operator decided to try to pull everything, the whole system, back to the radial approach. However, at that time, that you can see the stent just stuck at the brachial artery. So now the stent cannot come out and the guiding cannot come out, right? So what would you do? Two complications at the same time. So again, for PPCI patient unstable, we have to be calm and we have to do what we have to do. So we know that the stent dislodgement is not an urgent thing, right? We can deal with it later. So first we tackle the coronary first. So we get the femoral access, we get the guiding, and we balloon and stent, and we use different drugs, right, to try to stabilize the patient. So you can see we also try to rescue the AM branch, and now you can see the flow improve. It's better because of the drugs, and then patient have some clinical improvement after this. All right, so the coronary seems okay. We get some time for the coronary to recover and get some time for the drugs to work. So how about the stent dislodgement? How can we deal with that, right? So now the stent and the system stuck in the brachial artery. So what we did is that we tried to push the whole system back inside to the aorta, like this. And then we use a snare from the femoral approach. We get the tip of the wire and then try to get the whole system step by step from the radial brachiocephalic and then down to the descending aorta and retrieve that from the femoral approach. So this is how we do this, right? Step by step, one by one. All right, you can see calm, step by step, one person pull and one person push. So you can see now the stent gradually goes down to the descending aorta. You can see this is stent. This stent is forming this proximal edge, and you can see this is the proximal marker of the balloon, stent balloon here. Right, the whole system then goes down gradually through the descending aorta. But now comes the thing, right? So now comes the difficult part. So because now the stent at the proximal part is dislodged and also deformed, so it may not be easy to get down from the femoral artery. So you can see this is a 7 French JR4 guiding. All right, we try to slowly retrieve the stent system inside the JR4 guiding, right? But however, because now the proximal part is quite deformed, so this part cannot enter to the guiding catheter. So we release it. We try to upsize to an 8 French sheath, 45 centimeters fish sheath. We hope that now the sheath opening is bigger, and we'll be able to get the deformed stent back inside the sheath. Right? But however, sometimes it may not be that easy because now it's usually when we do all this, the stent become more deformed. More deformed, it means that the stent is more difficult to back into the bigger size sheath. So you can see now it's still stuck around here, right? Stuck around here. You can see the H-fan sheath, the opening is here, and the stand is all deformed and stuck around here, right? You can see we try hard, we try pull and push, but still we cannot get the deformed part back inside the H-fan 45 cm sheath. So we have no other options. Okay, we have to try to upsize the sheath, just like doing TAVR or other large bore device. Now we use a 14-fan sheath to try to upsize the system. Hopefully, because of bigger size, we will be able to get the deformed part back into the sheath, right? So you can see now we have a 14-fan sheath. But you can see even we pull on the wire, right, in the system, even a 14-fan sheath is still very difficult to get the deformed part back inside the 14-fan sheath. And worst come to worst, now the snare stuck with the wire. We cannot pull the snare out, and we cannot free the snare from the wire because now everything is twisting it themselves and make it very hard to retrieve. So the next step, right? Then we can use the biopsy forceps because now we have a 14-fan sheath. So biopsy forceps can actually do everything inside the sheath without damaging the aorta, right? So we can do everything inside the 14-fan sheath by using this biopsy forceps. So the reason the biopsy forceps work is that because the forceps grab the stand, not the wire. When you grab the stand, actually we can pull the whole stand, lengthen it to try to get the crumble of the stand, lengthen it into a wire or into a more thinner stuff, so you can put the whole system back inside the 14-fan sheath. So you can see now we grab the stand, right, and then we deform the stand, lengthen it, and then you can see now the crumbles part just release itself and get everything inside the 14-fan sheath. And the whole system now, wire, stand, everything we move through the right femoral approach, the 14-fan sheath. Now you can see, now the stand is lengthened, and you can see this is the crumble part, like this. And the snare stuck with the coronary wire. Right, so this is the final shot, right? Not the best, but still we have the TIMI free flow almost down to the coronary artery. And the patients transfer back to CCU, gradually weaning of the inotropic vasopressor and able to off everything in the next morning. All right, so ladies and gentlemen, in conclusion, so PPCI for STEMI is life-saving, but complications may still happen. So as an interventional cardiologist, we need to have the knowledge to anticipate and avoid and manage all these complications. This is essential for all of us. And in this case, we demonstrate how the management of snow flow by the use of hemodynamic support and intracoronary medications. And again, stent dislodgement is uncommon, but we have to know how to deal with this. So, ladies and gentlemen, thank you very much.
Yeah, thank you very much for your presentation. We still have another 5 minutes in order to discuss about this case. Actually, very interesting case, I think. So I let's say Dr. Brian, do you have any comment for him? Yeah, thank you.
Oh, it was a good save. I mean, I'm sure you took a long time. I think with this large stent, often you don't appreciate it. You have 7 French sheaths of the femoral, right?
Yeah, 7 French.
So you appreciate getting a much bigger French.
Yeah.
So I think if you have started with exchange to like say 12 or anything initially, before the stent becomes very distorted, you maybe get out. So once it's getting jammed,
it's difficult.
So I think the key thing is to go really as big as you can.
Yeah.
And you may have skipped a few steps.
Yeah, I could agree. So I think the experience I got in this case is that, I mean, when the stent is deformed like that, so it's actually very difficult without deforming the dislodged stent itself, right? I think in the very beginning, we may be able to get it if you have 8 French, 7 French. But once it's beginning to crumble, then I think we have to use something to deform the stent, just pull it into straight and then take it out. Otherwise, it's very difficult.
I think Dr. Denwilden will have some comment because he has worked from peripheral intervention, and I think look at the very huge sheet to put into the femoral artery. So I think, do you have any comment for this?
So it is a very nice save, but I just wonder how many interventionists here have the biopsy devices in their cath lab. We don't have this one.
Oh.
We don't have this one, and I'm sure that not every cat lab in Vietnam have this fancy device. I wonder what can you do, sir? If I had this case, it would be very tough, but I think the only way to do that is to upsize the seat. So we can upsize to 18 to even 22, 24 French seat if it is available. I'm sure that the 18 French seat is available, and we do hope that it can help.
Yeah. I think if we do not have the biopsy forceps, I think another snare to try to not grab the wire, grab the stent and deform it. And then I think it will just do the same thing as the biopsy forceps did in this case.
And another cheaper way is probably do in the mother-child system where you have a very big stent sheath, and then a slightly smaller, and then you're trying to get the tip of the deformed stent into that, so you don't feel like you're less like a catch. So maybe you can try to pull the deformed side into a slightly bigger sheath, and then a bigger sheath outside. So that may be one way of if you don't have a buffer biopsy force.
Yeah. I've heard a lecture by Dr. Sumitsuji from Japan. He actually said that not grabbing the middle of the stent to make it into a V may be an easier way to get this dislodged stent out. Yeah. Personally, I haven't tried that, but maybe next time, hopefully not. Yeah. Maybe grabbing the middle of the stent and deform it to V may be easier to get the things into the guiding catheter.
Smoother part,
yeah,
rather than pulling the big chunk of
exactly.
deformed.
Yeah, exactly. Anybody can get a mic? Yeah.
What I do is that I go from femoral access, we went in, and we capture the mid-stand, all right, exactly like what Sumitsuji did. Mid-stand, and then after that, we pull into the 7 French catheter, so they form a V shape, excellent V shape, and then we pull it, and then so that the radial catheter will snap, the balloon will snap, and after that, we pull it out, it exactly come out. So we don't have to upsize to 14 French. So always catch the weak point. The moment you catch the center part of the stand, it becomes a V, and the stand is actually very flexible. The moment you form a V, it will ultimately come out from the 7 French catheter.
Yeah.
I have a picture of it if you want to see. All right.
Sorry. Dr. Song, so what did he use to capture the stent? How did he capture it?
The snare, the best snare is actually just now Dr. Tam actually showed the lotus stand with three pellets. That's actually very good because it actually, it will capture it easily. But always capture the middle part of the stand or, somehow along the way. So that's the weakest point of the stand that will actually easily for you to pull out.
Great case. So many learning points from this one case, right? But you do a lot of complex structural work as well, so you're familiar with all this equipment. Yeah. But I don't have biopsy forceps in my hospital either. I think one of the things I find useful when something like this happens is to get a friend to support. Yeah. There are so many things to think about, and we all have different skills and transferable skills. And I think that's something for us to think about when you get stuck. Get a friend to help, and so we can think through and prioritizing. It's an important point you made. Stent, we can worry about it later. Fix the MI first. Fix the artery first. So great learning points. Yeah. Thank you. All right. Thanks a lot, Frankie. That's a great case. Thanks very much. The next case is by Dr. Do Van Chien from Vietnam. So we're going to talk about ECMO-supported LMS primary PCI. That sounds like a really complex case and a lot of learning. Thank you very much.
Dear Chairman, dear panelists, guests, thank you for inviting me to this very interesting forum. So today I'm going to present ECMO support primary PCI in very high risk, bleeding risk patient when electrical storms. So what we can learn from the case. Can you see the screen? Can you see the slide? Okay, yeah, thank you. And so this is, I'm talking about the timeline, 60-year male patient, a smoker. He came to our hospital 2 days because of the abdominal pain. So the abdomen is very episodic, pain score about 4 over 10, no fever, no abnormal urine phases, and no vomiting or chest pain. So the patient has a history of cholecystectomy and hepatozoonium stomy. So he come for the admissions. So on the examination, we didn't find anything except for the pain on the palpitation on the right upper quadrant of the abdominal. So the EKG at the admission is normal. Cardiac echo is about 68%. So the diagnosis for the admission was the recurrent hepatic stones, and he was planned and did the surgery for stone removal. So 5 days after surgery, about 9 p.m. during my shift, he got a very severe acute left chest pain, a pulse constant and pressure-like, pain score about 8 over 10, radiate to the left side and diaphoresis and sonnet of breath. So on the EKG, you can see that the ST elevation in AVR, V1, and ST depressions in V1, V2, V4 to V6. While waiting for the cath labs activation, actually in our cath labs activation is very long time. Patient collapsed the VFib on the monitor, and we applied multiple shocks, and the rhythm become too normal after the shock. And you can see that's ST elevation D2, D3, and D3. So what you can see here, the left main is the most very severe. Sorry. You can play here. The RCA also occluded. So after diagnostic angiography, the recurrent VFib again, and after defibrillation, he returned to become normal. You can see on the screen. What we are going to do for these electrical storms. So we have the current problems is patients that's 5 days after the surgical open cholecystomy, very high risk, bleeding risk. He's not yet on any antiplatelets or antithrombotic therapy. Hemodynamic is unstable due to the electrical storm, but luckily he returned to normal risk. And patient is very high risk, very high complex procedures. And we discussed about urgent CABG. So in my cath lab, we wish we have an impeller for this kind of patient because patients that have dynamic is very well. What we know from the danger shock randomized control trial confirms that the routine use of impeller can help patient survive in this cardiogenic shock patients. You can see that that's published now, and that's, if we have that device, I would put for the patients. About the ECMO for the electrical storm treatment, we so far don't have any enough clinical evidence. Some people like putting the IABP because we have a lot of experience. It's better than the outcome compared to the ECMO. And actually, several successful cases reported that we can use via ECMO for cardiogenic shock patients, especially with the VFib like this. And you can see that when we have a successful ECMO, it can save up to 50% of survivor patients in the clinical studies that's published now. For the ECMO primary PCI backup, there's no randomized control trials comparing ECMO with the other mechanical support system in cardiogenic shock patients. However, observational studies show that patients with the ST elevation related cardiogenic shock who are undergoing PCI can have a good 30-day lower mortality compared to the one without that one. So via ECMO, we can just rapid insertion. We can have a good tissue perfusion. But actually, we have increased the afterload for the left ventricle. And the cannula for the ECMO is quite high. It's for the artery about 15 to 16, and for venous is about 20 to 21. So actually, the complication of the ECMO, as we know, this is bleeding, the limb ischemia, and sometimes we have face infections. So this is my patient. You can see that he just 5 days after the operation scar. We take a video after the PCI. For this kind of patient, do you want to do the CABG? We discussed very consistently and intensively. Yeah, patient is not on any antiplatelet, we can go for this. And the risk of intraoperative infection is too high. So surgeon refused to do. So we prepare for the ECMO cannulation. For the cerebral arteries, we see that there's stenosis on the left carotid arteries. For the iliac arteries, we see we have only the right side to use for the ECMO. We don't have that, the left side to do the intervention. So for those who just start doing the ECMO insertion procedures, most of complication occurs when we insert the venous catheter. It's very big. And the venous vein is very thin one, so sometimes we just make punctures in the ruptures of the venous arteries. It's very cautious to do the first step when you do the insection. For us, it takes about 10 minutes to everything, something like that, when you go for the RCA. So you see that the thrombus burden is very high. So one of my colleagues who are doing neurointervention, he wants to do the very interesting thing. He used Pegas, Trimax thrombus retrieval system to do so. And you can see very clearly that we can remove the thrombus. Very interesting. It is the first time we did that case. So, I don't have a lot of experience, but I want to show you that this is the way how we can do in our practice together with neurointervention colleagues. So we can see on the right side that the thrombus was removed, and we put 2 stents in the RCA. It's quite good. For the left main, it's more complex. What we are going to do? So the left main, you see that the very tight lesions. So we try to do is less complex. Just when we balloon, the left main heart stop working. So this time is ECMO is very useful for this case because without the ECMO, you are maybe fail to hemodynamic compromise. So in my practice, I more and more use the PCI with the ECMO supported. So you can see it very clearly. So afterward, I put the 2 stents in the left main, from left main to the LED, and then the patient is survive after this. So it's a very tough question now here is antithrombotic treatment. You see that the patient is on very high risk of bleeding. So would you do the prasugrel or ticagrelor? So my choice is that I follow the guidelines. I use clopidogrel together with aspirin, and I think that we can use it for 6 months. And after everything was done, the hemodynamic become very normal. You can see that SpO2 improve, the blood pressure also improve. So after this, would we remove the ECMO or we keep it for a few days or few hours afterward? And I think the reason here is because of the occlude of the RCA and the stenosis of left main. So I decide to remove the ECMO after the case, try to avoid the left ventricle afterload. So this is my take-home message. ECMO-assisted high-risk PCI became more and more common in our clinical practice. Total revascularization in cardiogenic shock is still controversial. The guideline doesn't tell us to do, but we have to need to do the individualized approach. And lastly, try to apply what we have in cath labs, the devices, the operators, your friends, together with you. And together, we can do the better work. Thank you very much.
Congratulations for the successful case. It's wonderful for the RCA total occlusion lemon orifice. I have a question to you. For your setup, the ECMO team, so how long you can set ECMO team from after coronary angiography? Thank you.
About 10 minutes, because easily in our practice, now we try to apply more and more ECMO support devices. So we set a very big trolley. So everything inside this trolley is especially designed for the ECMO. So the process, it takes about 10 minutes maximum. We can just start from the diagnostic angiography together with other maybe surgeon backup and many other experts together, and we do it now very frequently in our cath lab.
Yes, thank you very much. And I think we still have time for asking the question. I would like to have the comment from the Dr. Sozo that because the afterload for the patient like this, so is the problem for the ECMO actually. So what do you think about the applies ECMO in the clinical practice, like a patient in shock deep, like shock C, D, and E? Thank you.
Okay, so for me, so I also do the same procedure, so introducing ECMOs. But in Japan and in some countries, Impella is acceptable, so we can use Impella. But so, as you know, Impella is very expensive, and also the limited hospital can use the Impella. So if your hospital can use the ECMO, this kind of electrical storm at that time, the ECMO is very useful. And so of course IEBP is sometimes helpful, but so in this kind of situation, ECMO is mandatory. And so for me, so right side is very looks it's easy, but so very tough thrombosis, a lot of thrombosis. So that for me, maybe left coronary, I will treat first, and then I try to right side. And so it is first time to see the thrombus retrieval system. So it's very interesting. Thank you.
Yeah, thank you very much for the comment. But actually, in our practice, we have the very strong ECMO team so far. Now we don't use IABP anymore in our just for the very high risk case like this. I don't know about the other places, but personally, I will pro the ECMO export because I think that the perfusion, organ perfusion is more important than the perfusion of the coronary arteries. Yeah, I don't know your idea about this one.
Dr. Tang Tae Yang,
yes,
have some comment.
Some comment because we have some cases like that. So this patient, we look at the patient status. Firstly, I would like to know that the blood pressure after electric shock and how dose of inotropes we use for this patient to indicate the ECMO or not. Because when we use ECMO for high risk bleeding patient, after ECMO we need to put a high dose of heparin to keep the ECMO activated. The second thing, I focus on the anatomy of lesion. So the left main is quite complex, but not very complex. We can PCI is a symbol by stand from left main to LAD, not direct to circumflex. That because a little bit complex because there is some calcified lesion from left main to LAD. We need to pedilate or you rotabilize as quick as possible. So in this case, ECMO, it's easy to doctor to do PCI because we have a lot of support for hemodynamic, easy. So to indicate ECMO, we need to focus on the heparin after that because we'll make the patient have some problem with bleeding. So you can give me some information, the patient's status.
Yeah, actually, after the shock, luckily the patient become just hemodynamic quite stable. We use a lot of cocdarone, we use a lot of lidocaine to keep the rhythm. However, sometimes it's the shock return, but shock is okay. He can keep for 10 to 20 minutes, it's okay. But actually, in my hospital's activation, sometimes that the lab is too busy. Yeah, so the patient have to wait maybe 1-2 hours to do the primary PCI. So it's a problem. So I think for ECMO it is the good solution. On top of that, I want to emphasize that when you do the ECMO, the interventionalists are very calm because the tissue perfusion is so good that you can choose either left main, as Dr. Zhang said, or the right side, up to you. Because in this case, I believe that 100% of you will do the total revascularization. You don't choose either left main or the RCA. So I think that we can have either choice is good. Yeah.
Sometimes I agree with you when we do PCI total, right side, left side. So in right side, obviously there are some doctors anatomy, and we is of some difficult that. But I see in the guiding catheter, it's not so much because you GR. But it's for torture like that, for acute, we need to PCI very fast. So guiding catheter support is very good for visual arm blast, right? Okay. So with the device of Thomas, I see you stand retriever device. The very expensive for some other cut lab, they don't have this one. Yeah. So to give the thrombus out, we need to have support guiding catheter.
Yeah. Thank you.
Yeah, thank you very much. I think we still have questions, but the time is a little bit over for the presentation. So I think we will come back to discuss more about this case because I also have the case like that. So I think in this room also have the people send the patient to us sitting in the floor like that. So I think we move to the next presentation. I would like to invite Dr. Puris from Thailand to present a topic about the with the entitled "How to Prevent and Make the No Reflow in ACS Patient." Dr. Puris, please.
Good morning, everyone. Thank you, Chairman, Co-Chairman, for giving me an opportunity to deliver this topic today. So my name is Pulish from Thailand. I think someone control the slide for me. Like, I cannot control the. Okay, so scope of my talk is about overview of no reflow, risks of no reflow, tip and trick to prevent no reflow. So everyone knows the definition of no reflow, apart from the nightmare of PCI, like failure to restore vessel and microvascular perfusion despite treating and opening an occult or stenotic vessel. And no reflow phenomena predict 5-year mortality rate. So the death rate will increase if we perform PCI and get no reflow. Risk factor of no reflow for clinical female, elder, hypertension, diabetes, hyperlipidemia, Shadwell score more than 3, delayed presentation, CKD, increased inflammatory marker. For the angiographic, high thrombus burden, plaque composition, reperfusion time more than 6 hours, SVG PCI, longer lesion. So about the strategy to prevent in terms of PCI only, not the medication. So this is what I gather from the evidence base. First, try to direct stenting if possible. If no calcium in that ACS lesion, you can do the private stenting. Imaging guidance if possible. Avoidance of high pressure post-dilatation should be considered. So avoid of the perfect PCI. So this is 41 years old male, STEMI inferior wall, show some clot in the RCA. So we can direct stent in this vessel easily. Use a T5, 30 direct stent, and then finish the case very well. Second is deal with thrombus carefully. So we have a grade of a thrombus. If only grade 0 to 1, you can do direct stent. Grade 2, 3, aspiration thrombectomy. Grade 4, 5, you might need the mechanical thrombectomy or the M stent, the retrieval thrombus as you saw before. Current recommendation downgrade thrombus aspirator a lot, but I know that most of the physician rooms still use it. So no indication for routine use, but from the JCS guidelines, still recommend as class 2B for the bailout manual aspiration thrombectomy. For non-STEMI, no benefit. What is the evidence base? So because a meta-analysis of manual aspiration, no benefit in decreased mass or horse mortality, as well as a lean function, target vessel rewards. But somehow the significant endpoint are TMI, TBG4, and ST resolution. So why not we use it in the high thrombus burden? This is 48 years old male with STEMI at the inferior wall. During preparation at the cath lab, the patient developed VD-FIB, and CPR for 2 minutes. And then after that, we immediately do the angiogram on the right side. So the RCA show a lot of thrombus at the distal part. So we do the conventional PCI. We try to aspirate the cord with a 7 French thrombustor too, but somehow the flow was not retrieved. And we aspirated for 10 times and still no flow. So this is the cord that we retrieved that day. It looked like a late review at the midnight. So we use this device. This device is an angiojet. So we use we give inticulin and put the angiojet in, and then we use an angiojet for 40 times. Angiojet is a mechanical aspiration. So after 3 times of angiojet usage, the flow was retrieved. And then we downgrade the thrombus burden from grade 5 to grade 1. So next step, I direct stent in. Using a 3.522 direct stent, just inflate it and finish the procedure. But I kept the patient in the ICU for 48 hours, and then I gave the enoxaparin for 1 week, and then I re-CG 1 week later and show it the thrombus was gone. This is the angiojet device. It's give flow at the proximal part, and then they retrieve the cord at the distal part. But for using in the RCA, please be careful of a complete heart block during the angiojet. Some physicians recommend to use the temporary paste to prevent the heart block during the procedure. And the very promising device that coming in Thailand, and we can use it in Thailand now, is the P-number CAT RX. They call it mechanical aspiration, but I feel you can do the homemade aspiration using the mother and child catheter and attach it to the suction machine and suck all the clot out. So the mechanism is like that. So from the Cheetah trial show that using P-number, you will get more flow compared to not using it. And third, use intracoronary imaging. So IVAS guidance for P-stent, you can measure the vessel size, plaque composition. So be careful when you direct stent in the calcium lesion. So it's never open and will get you more complication. You can aggressive stent sizing and length to avoid post-dilatation using an imaging. This is the diagram of how can you sizing the stent using the IVAS, but you can look in the reference. And you can evaluate post-stent to check for the optimization of the stent. So this is a 57-year-old STEMI anterior wall failed SK with a severe cardiogenic shock. And the LCA look like this. The distal left main lesion with ectatic chain at the distal left main. The RCA have some 80% stenosis. So what should we do? I just wiring with the Xiongbu Y a little bit of dilatation of the LED to see what happened of the vessel. So the proximal was very ectatic, and I performed the IVAS as this lesion. So you can see some calcified, and most of them are plaque. And at the proximal lesion, there are a lot of thrombus. So hypoechoic thrombus like this is very likely to be a chronic thrombus. Yes, so it looks like this. A lot of subacute to chronic thrombus. So if you use the high definition IVAS, like 60 Hertz Boston IVAS, you can differentiate the cut into three states. Acute look bright, subacute look light to dark gray, and subacute with attenuation. Be careful for the no-leaf-4. And the organizing thrombus will look very dark. Okay, so you can differentiate it. So I avoid left main, so I just put the stent at the taper tip of the ectatic part, and I stent thing in because I use the IVAS to see where should I put the stent in. And IVAS after performing the PCI. Okay. Oh, I cannot skip to the stent part. But believe me, the stent expand very well and have a good opposition. Okay, so next, number 4, consider distal protection device in Saffinat vein graft, STEMI, huge thrombus, attenuated plaque. So why we should use the distal filter protection device? Because sometimes thrombus is a lot. And every time you dilate, thrombus will go to the distal part. And the more thrombus you get at the distal part, you will get no leaf-4. You can put the distal protection at the distal part, do the balloon and put the stent in. And then you capture the thrombus and remove the filter out. Because my distal filter protection device is very long case, so I cannot show you today. So next, my last tip and trick. So when low diameter in ACS, keep it slow or delay, maybe give anticoagulant for 1 week and then redo the PCI using the low diameter. But if you cannot avoid it, please use a low speed. Low diameter, give avoid pellet application by ensuring the APT is given well before starting the case. Avoid high speed, correct burst size using an IVAS. If possible, short run less than 10 seconds. Avoid rapid deceleration. This is a 60-year-old male present with STEMI for 2 hours. You can see the ST rate very well. And transfer for private PCI. So this case was in the private hospital in Bangkok. So I think it will be the very quick case. And when I do the CEG, it shows that the patient have a osteostomy, occlusion. So I put the Xiongbu in, and the lesion caused very difficult. Aspiration failed to cause, and 2015 was failed to cause as well. So what should we do next? Mother and child catheter, chain guiding catheter, use body wire, or use extra support wire to put the balloon in. So I changed to the larger size guiding catheter with a guide pass as well, but somehow 1.25 balloon still cannot go down. And the flow look like this. 1.5 can go a bit, and it showed that it was undilatable. So what should we do? So my tip and trick begin with the low diameter. So this case, going on to do the low diameter. So file cord could not go down and difficult to bear while LOTA. As you can see, that it's a bit tricky at the middle part of the LAD. But somehow I managed to bear while LOTA in. And then begin low diameter. Actually, I want to begin at the speed around 140,000, but it cannot go down, so I have to increase the speed up and up to 180,000 to get the burr in. And after T round, so I dilate balloon. Every time I dilate the lesion, it's no leaf-4. So I use the 5 cord at the distal LED and gave nitroprusside for 2 times. And then I put the stent in and 2.5 and 3.5. After 3.5, still no refill again. So when no refill occur like this, so it's the endpoint, so you should treat it. So you can use adenosine, verapamil, dihydrogen, nicardipine, nitroprusside, whatever you want on the shelf. So in the center, we have nitroprusside, so I give nitroprusside 4 times, and then the flow was finally retrieved. And this is his final, still low flow. So I gave him the enoxaparin again. Okay, post PCI EKG going down a bit. So factor associated with difficult in causing the culprit lesion. One of the factor is the moderate to severe calcified. So when you encounter with difficult wiring in the STEMI, please be careful for the calcium. And from the Boston recommend, so no rota in the thrombus. You should give it enoxaparin for 2 to 4 weeks and then redo again. And for only the non-STEMI multi-center GC trial show that the slow fall will occur if you do the rota better in non-STEMI. Diagram to prevent the no refill. And my first take-home message for STEMI, early recognition of the leaks, shorter the time, consider aggressive thrombectomy upfront, IVAS if possible. When graft intervention, fix native vessel if possible. If you cannot avoid precise to the vein graft, STEMI, use the distal protection device. And atherectomy, I think should consult the expert first and then do again. And for Thomas, this is the other cause of thrombus. Okay, thank you for your attention.
Thank you, Purish. There's some beautiful cases and great points about the use of IVAs and the use of drugs as well. Now, in STEMI with a large thrombus burden, one strategy might be to just give some drugs, some gentle dilatation, restore TIMI 2 or 3 flow, and bring back 2 or 3 days later after some good pharmacotherapy to think about stenting. Is that something you try or practice often in your practice?
Yeah, so most of the case I will just a balloon, and when the fall occur, I give the intralesional thrombolytic. But in that case, they still got the VFib and have to shock and CPR. It's very long case, so I don't have time to tell you about this case. The also of PCI.
Yeah, I want to mention one comment. So you said about the NTP, nitroprusside. It is a very important drug for the slow flows, even after the rotablator slow flow. In Japan, most of doctors use nitroprusside, the first choice for the slow flow, no flow, instead of nitroglycerin or verapamil or adenosine something. So that I visit many countries, but so they have no nitroprusside. It is very cheap drug, so that please prepare. It's very important. Thank you.
Can you, just for everybody's learning, your practice of using thrombolysis, intracoronary thrombolysis, how do you do it? What drug do you use?
So I think it depends on which medication, but in Thailand, the SK available in most of the hospitals, so I will give it solely like 100,000 a time and then recheck the flow. If the flow not retrieved, we'll give other 100,000 again. Okay. But
yes, I think we have one question from the audience. Dr. Hill.
So thank you very much with the great presentations. So I would like to make two questions. The first question, if we see the image with the large thrombus, whether we have to make sure by the intravascular imaging. The second question, with the medication, so far we have the evidence for the epinephrine and adenosines. So which one you have to refer? Thank you.
For the like a lot of thrombus, like
yes.
So for last thrombus like this, I will give the upfront GP2-BTA, add up abscissimab or atipiatide, whichever you have, and then I will aspirate a lot of time, more time to retrieve more clot before put the stent in.
Yes.
But this case, because I saw in the IVAS imaging, there are some landing space beyond the thrombus, so I put the stent in first to optimize the flow, and then I aspirate clot again. So I think it's an individualized patient and with situation that we encounter with. Yeah. But I'm not sure that I answer your question clearly enough.
Yeah, yes. Thank you. And the second question, with the which one medication you have to refer with the last numbers we got the no reflow, adenosine or epinephrine? Because so far we have the epinephrine is better than adenosine and other medication.
I think it's a very good question. I use both. But for adenosine in the RCA, I'm afraid of the heart block. So I try to avoid it. I prefer NTP, nitroprusside more. But for dilute, you should dilute it into one how can I say, divide by 10 to 100 and give it slowly to prevent the ventricular fibrillation. I use it before, but not in many cases.
Yeah, thank you very much.
Yeah, thank you very much. Thank you for your presentation. Really interesting. So I think we still have the question, but I have to. I would like to ask Dr. Professor Brian. Could you help me to introduce, advise the next speaker for me? Thank you.
Hello. So the next speaker is Dr. Chung Yun Sin on PCI calcified lesions with intracoronary lithotripsy assisted.
Good morning, everybody. Thank you for having me here in Saigon. Today I want to talk about calcified lesions. Usually in calcified lesion, we will deal with either rotablators or actually nowadays we have a new toy called intracoronary lithotripsy or shockwave. I started to move less and less from a rota to actually more into a shockwave. If the shockwave doesn't work, then I move back to rota. Right? So nothing to disclose. Let's start with first case. I have a 60-year-old man actually came in to me, and then this guy is a smoker for the past 20 years, diabetics, hypertension, cholesterol. Came in with chest pains, functional class 3, ECG actually show anterior ischemia. EF at that point in time with the echo is LV 35% and anterior wall hypokinesia. So the angiogram actually showed that triple vessel disease, left main is 50-60% distal disease, LAD, severe heavily calcified lesions, very long lesion, proximal to mid segments. Circumflex, 80% calcified lesions, RCA, diffuse disease. So this actually have severe triple vessel disease with the left main. As usual, we have a heart team. We actually recommend either bypass or multi-vessel PCI. So this is an angiogram of the LAD and circumflex. You can see the left main is distal vessel disease, and then the LAD is a calcified, long lesion, angulated osteo segments. Circumflex is severe calcified disease as well. So this is a epicranial view. You can see the LAD long calcified, you can see the calcified lesions, long diffuse disease. The right is not that bad, but there's a lot of distal vessel disease. So what we did is that I actually assess a patient. Usually we will do a calcium score. So I roughly know how heavy is the calcium so that I can prepare the patients what to do next. So in this patient, the calcium score, you can see the LAD is heavily calcified. The calcium score in LAD is about near to 3,000. And these are the cases that we usually will encounter some sort of problem. Either we do a rotablators or we do an intravascular lithotripsy. In my centers, we always assess a patient, especially with a poor EF, severe coronary artery disease. We want to know the viability of the muscles, all right? So in this case, the EF is about 30-35%, dilated LV. You can see some delay enhancement in multiple segments, but overall, the heart muscle is still viable. So in that case, is that any revascularization will benefit this patient. So this patient, to summarize, have severe complex calcified lesions. So we plan for multi-vessel PCI with intravitreal lithotripsy, and I was assisted. We come in with a 7 French PL30. So what we do is that you can see that the LAD is long calcified lesions, circumflex as well. So we fix the circumflex first with a drug-coated stent. You can see the result is fairly good. Then we come to the LAD. The LAD initially I actually put in a rotablator 1.25, but because you can see the angulations of the catheter, the LAD is angulated, and when I put in, I can't advance the burr. Then I know that there's something not right, because if I push it, I may actually perforate the vessels and things like that. So I decided to change my plan. I switched to a shockwave. So what we do is that in this case, you can see this is an acute angulated at the proximal segment. These are the challenges I have. It's a very calcified LAD, calcium score is about 3,000. Long segment from osteo to mid LAD. Small diffuse vessel disease, unable to deliver the IVUS and unable to deliver the intravascular lithotripsy, and difficult to deliver the rota as well. So these are the difficulty that we encounter during the procedure. So in order to do that, we actually put in a guide extension. I love guide extension nowadays. So guide extension will assist me to go into where the lesion is, and I slowly advance the shockwave catheter. The shockwave I use is 3.012 with a guide extension. And you can see that with a guide extension, I was able to push in the shockwave catheter. So this is a shockwave has come to me a couple of years. So it's a 12 millimeters length, and we have size of 2.5, 3.0, and 3.5, and so on. So we can usually I use it for all the calcified lesions. Either is you can see there are many forms of calcified lesion. It can be a concentric, eccentric, nodular, and so on. So in terms of calcified lesions, is that a balloon will be very helpful, in certain type of calcification. But the rota, let's say it is a very tortuous and things like that. Sometimes it may be difficult. Intravascular lithotripsy is actually very useful because it is same like normal balloon. You can just push it, but it's just that the balloon profile is a bit difficult to push because of the profile is a bit hard. So a lot of time we need to use guide plus or the guide extension. So this is after post balloon angioplasty, you can see that I managed to open up the vessels. So this is you can see how the intravascular lithotripsy actually, when you expand it, you can see that the calcified lesion actually expand. You can see that how the balloon expanded, and the sometimes the general rule when we do a lot is that if let's say your IVUS catheter can actually pass through the lesion, then your shockwave catheter usually can pass through easily. If your IVUS catheter is having problem of passing through the calcified lesion, in that case, usually the shockwave balloon is difficult to cross. Then you have to use some other devices like a guide extension and so on. So this is how we actually shaft and unshaft the shockwave. So basically, is that if you have a lesion there, you actually bring in the guide extension all the way down, and then you shaft it into the balloon catheter, and then in the shockwave, and then you move on. You shaft the guide plus or the guide extension further down, and then you move on with the balloon, and that is the same technique you use for stenting later on. All right, so this is we have problem because it's a calcified angulated vessel, so we have problem of delivering the stent as well. So we use a guide plus and a guide extension, so we push all the way down to the mid LAD, you can see that. And then from there, then the stent actually can go through. Without the guide extension, we can't actually push down the stent. So subsequently, we put in 3 drug-coated stent, 3 in the LAD, mid proximal for 2. We upsize to the 3.0 and 3.5, and we assess with the intravascular ultrasound to see how the stent well exposed. You can see this is the final result is very nice, I would say that. You can see that the flow is symmetry flow. This is, you can see the circumflex and LAD is nicely good flow. So in conclusion, shockwave today is actually very helpful in terms of calcified lesion, but it's actually an alternative for some calcified lesion, but not all, because sometimes if the balloon cannot cross, the shockwave balloon cannot cross, you cannot deliver the shockwave. So some of the cases is that if I cannot deliver the shockwave, I actually switch back to rota. And shockwave is actually very safe. If you know how to use your normal balloon, you can actually use a shockwave safely and easily. All right. With that, I just say thank you.
Yes, thank you very much for your excellent presentation. Actually, we don't have the IVL in Vietnam yet, so I think we should ask the question from after Dr. Wei Chung Huang and then Dr. Raj about the IVL application in this situation. And for you, I have a question that because when we put the attention guiding catheter and then you put the IVL catheter in, so how do you cope with the situation that you can cause the ischemic time for the patient, so the patient can be collapsed on the table or something like that? If you keep that too long, and do you need to use the IVB balloon or impeller device in order to have support for the patient in this situation or not?
We know shockwave balloon is actually, now we have basically 12 millimeters. So each time you put in, you can deliver, the first generation, you can deliver 80 shocks, all right, 80 times. And the new one is up to 120 times shock or pulses. So what happens is that each time
before that, because you have to use the attention getting catheter, so you caused some ischemic time already. So then after that, you put the balloon in. So do you stop in the middle in order to make the myocardium take time in order to recover before we start the pulses of the IVL balloon?
I don't think any problem, because once we put in when we put in the balloon, we put in 10 pulses. 10 pulses is just a few seconds. And it's actually shorter than when we put the drug-coated balloon. Drug-coated balloon is recommended for 30 seconds to 1 minute. It's much longer. So a lot of time you actually monitor the ECG changes. A lot of time when we put, as an example, like drug-coated balloon, the moment you see the ST start to going up, we say, come down, balloon down, balloon down. So for intravascular lithotripsy, I never encounter ST up. But sometimes you do realize that they're actually pacing the heart. They're actually pacing the heart. But there's no ischemic changes.
So I would like to have to hear the comment from Dr. Wei Chung Hwan and then Dr. Ta Yang also.
Thank you, Dr. Ngô Minh Hùng. So I don't discuss about the IVL because IVL now is not available in Vietnam and I don't have experience. But I just focus on the coronary lesion. So first, you can see here, with this patient with a lesion and circumflex, we don't need to PCI. The medical treatment is best for the patient. For the lesion in LED, so I see you put 3 stents, right? 3 stents.
Correct.
So long stent from the digital LED to the proximal. So with lesion, when we see again the CAC of LED lesion? Can you play back again? So with lesion, we don't need to PCI the digital. It's a very narrow lesion in the digital of the LED. So for this lesion, we discuss about the stent or DCB only. I see we can pedalate with balloon. From my experience, firstly, I just pedalate but small balloon with a 2.0 mm balloon to pedalate first to check the lesion, and then we can use non-compliant balloon, or we can use 2Y pedalate, and the DCB if DCB is the after pedalate is good. The DCB leave it alone. Don't need to put stent in there because long stent is not good for patient.
Yeah,
for the proximal and the middle, I see the lesion is not tightly, is not make the patient with high risk in the future for ACS.
This is the LED lesion, which is a prognosis vessel. Usually calcified lesion, if I ballooned it, it will definitely crack. You will have as you can see, after the balloon, you have multiple dissections. I will not leave it with a DCB. I would always stand it.
Okay, dissection is good. That's the equal for DCB. If dissection is not make to slow flow or not high risk for acute occlusion after that, in my experience, I just put DCB and leave it alone.
Thank you. I think the answer is somewhere in between.
Okay.
I think, I don't think it's a question of only doing DCBs or having to stent every time. I think, we've done lots of cases where we've done IVL followed by DCB. I think you do IVL, you do your NC balloons, and then assess. And like Dr. Chong said, in a proximal LAD, if there is any doubt, you want to have a stent in there. But also I agree with Dr. Tran. I think in a distal LAD, as far as possible, you want to put in a DCB, avoid a stent, so that in the future, just 60-year-old woman, right, or 50-year-old, might need CABG in the future. It's nice to have a target for Lima. I think that's decisions made at the end of all your vessel preparation. And its idea is not to avoid stent, it is to minimize stent. And I think you find a balance. Dr. Wang.
Yes. Actually, IVL has already launched in Taiwan, but because very expensive, and we cost about 3,000 American dollars for each one, the insurance doesn't reimbursement for the IVL. But I think IVL is a very hard issue in the future because more companies to produce IVL product in the future. I have a question go for the Dr. Singh. But in these cases, how would you choose ROTA or IVL? Which one is the better for this case? Thank you.
I guess I'm both operator for ROTA and intravascular lithotripsy. I tend to use, those days I tend to use a ROTA, but the setup is a bit of time consuming. For IVL, it's very easy. It's just like a balloon inflate and that's it. And the setup is very fast. So if I look at the cases, if I feel that the IVL will work, I usually just do with IVL. And most of the cases have ROTA, which I actually convert to IVL, it works perfectly, unless the lesion cannot be crossed with a balloon or IVL, cannot be crossed. It's just like the Dr. Pri just now. I have a case like that. The balloon just cannot cross, IVL cannot cross. So I switched to ROTA and 1.25 easily. So once the balloon cross it, the ROTA cross it, everything becomes very easy. So I guess the future moving on is that two options, you have two toys to play with. We depend which one you like it. But IVL setup is easy, so you can try IVL first. But if you think that this one's balloon have difficulty crossing, I said ROTA will be the first one to move on.
So I have a concern, the same like Dr. Minh Hung, that you put the guide plus in, the guide extension in for so long. So did you concern about the ischemia, or did you use any preventive measures like side hole guiding?
No.
Okay. Or you shorten the time, or sometimes how you can optimize the result? Yeah.
I do a lot of deep sits, deep throat, the guide extension into the mid RCA all the way in. Sometimes I need to, but I do it very fast. Very, very fast.
I second that Dr. Chong is a visiting consultant of Brunei, and he has a reputation of being a very fast operator, but he's also a very experienced operator, so not all of us can do what he does.
My PCI skin to skin single vessel is 8 minutes.
So yes, thank you, Dr. Singh. Thank you very much. Because that's the reason why I asked you that kind of question, because you do the procedure very fast, but for someone like a beginner, they start slowly, and then the patient collect on the table. That's the key point, the key question. So thank you. Because the time is over, so I will go back to the.
Thank you.
Thank you very much. Yeah, so I would like to invite the next speaker, last but not least, Dr. Hiếu from Vietnam, to present the very interesting topic with the entitled that how to treat the non-STEMI with 001 Lepman disease. Dr. Hiếu, please.
Okay. Good morning, everyone. Thank you, Chairman. I'm Dr. Hiếu from Tâm Đức Hospital. So I would like to present the topic with how to treat the non-STEMI with the 001 Lepman disease. So first of all, we have to see the patient. This is a male patient, 53 years old. He was retired, and he got hypertension and smoking, heavy smoking. And he come with a regular checkup and admitted in local hospital due to the typical chest pain, transferred to our hospital for further evaluation. So this is the medication he's on regularly with the antihypertension statin. So on the ED, he still the mild chest pain, but the pulse normal, blood pressure is normal. We can see the X-ray. This is the X-ray number range, and we can see the KG with the standard rhythm, no change ST assessment. So for the investigation, we can see the lipid profile very high. And the drop eye, we did it 2 times in recent. The first one more 400, and second time more than 1,000. And we did the echoangiogram. We can see the no hyperkinesia with ejection fraction around 63%, no dilated LA and LV as well. So we diagnosed with the patient. He patient got a non-STEMI, hypertension, dyslipidemia, and then we load in the aspirin and statin and other medication to solve the chest pain. So we put the patient go to the angiogram. So this is the angiogram for the patient. We can see the big lip man and LED as well, and we can see the lesion of the osteo or sac and the line aneurysm of the sac as well, very total vessel, and we can see the subtotal occlusion in the proximal sac. And another one special in the right and the left side, the LEDs with the non-significant lesion. So for the right side, so the heel vessel as well, but no lesion. So this is the issue for the patient. Patient got a non-STEMI with the left main disease, median lesion 001, and line aneurysm and total vessel. So the question, how to treat the median 001? So we make yourself about the question, and we have to make sure how important in the side frame, how the symptomatic is the patient, and is this the lesion the cause of the symptom, or we have to mention about the medical therapy for optimal therapy for the patient, and should be considered medical therapy first. In case we have to want to PCI, the question is what is the location severity of disease in the main vessel, and what is the angle between the main vessel and side brain, and are we prepared to stent in the side brain? And in case we need to do stent technique, we have to choose that. So this is the algorithm to determine according to the side brain relevance. We see with the non-left main bifurcation, we can follow the algorithm, and if left main bifurcation, we choose the phonetic relevant side brain, and then we decide for revascularization of vessel. So this is the proposed treatment of algorithm for the media 001 lesion. With us, we have to consider intravascular imaging, and dependent situation of the patient got ACS or the stable coronary artery disease. In case with patient got ACS, we choose the PCI, and thinking about the risk of the PCI overweight benefit, and then we choose the medical management of the patient. So this is the strategy for the treatment Medina 001. The first one, we choose the strategy with the non-stenting technique. So we have to make sure irrespective of the angle. And why both vessel, you will have to use the cutting balloon. We have to control the limit decision. And we control the DCB formation. And this strategy we can got the structural depth. And second strategy, we have to careful with stent positioning. We can see this is very design the stent placement just at the osteum. So we have to ensure the complete lesion coverage. We have to optimize visible acceptable. We have to use the stent boost, and we have to know the stent and the balloon marker. With the marker at the science stent angle, and the synergy with the 0.4 millimeter gap between the synergy stent and the marker. And stage 3, we have to use the stent drawback technique. We can see with the shaft, the angle, like T shaft, we have to use the main vessel balloon in place to low pressure, and we have to stay in the side brain and pull back again the inflate balloon until a then is seen. And then we have to stand in deploy the balloon remove, and both balloons are depleted. And the last series, we have to choose the stand. We have to choose the inverted personal stenting. We call the crossover technique. So this situation, if the stent extends into the main vessel, and we have to use the short balloon used to optimize the results. And if compromise to the main vessel, we have to use the TAF or Coulomb strategies. So combined with together one stent technique and two stent technique, So far, almost the lesion Medina 01, you use the one stent technique. We see the successful around 60%. And two stent technique, we can use the cross, staff, or culotte. So another technique we call the schematic of the shoulder technique. So we can see the balloon in the main vessel and the stent in the side brain, and then we can inflate the stent and inflate the balloon in main vessel, and then we pull back the side brain ostium and then delete the high pressure balloon. And very surprised, this technique we use the DAP in the main vessel. And the last one, we have to inflate the DAP. So back to my case, how I treat that. So this patient got a non-STEMI situation and line aneurysm and total shakes, which is a complete lesion. So need to revascularization for that patient. So we choose the non-stent technique. And we use the radar approach. And use the 6-brain EBQ getting catheter support. And use the double wires. So we see the first one, I use the NC balloon, which is small balloon, 2015, and then bigger balloon, 2512. You see the ostium objects are not implanted up. So then we use the cutting balloon, 2515. And you see the ostium is not implanted under expansion. And then we use the scoring balloon, 13, and inflated at 14. You see the same. And then we use the NC balloon, bigger balloon, 3015. And then 325-15, inflated at 10 to 14. And then we can see the ostium is better. So we choose the DCB 3525. This is a short on the long DCB because at that time in the store we just got that DCB. You can see the DCB is inside into proximal CX and left hand as well, and implanted that. We keep that around 60 seconds. And we see the lesion in the mid CX, very tight vessel. We cannot put the balloon into the mid CX, so that's why we just use the small balloon, NC1515. And then bigger balloon, 2515. So this is the final result. We just use the DCB in the proximal CX and the mid CX, we just POPA. So after 4 months and up to now, patient no chest pain, no sudden breast, more comfortable toleration exertion and tolerate with the medication. And echo we can see again 66%. And we did the CTTI for the patient, and they mentioned about the lesion in the proximal CX that 20 to 30%, and the mixed CX 30 to 40% as well. And we measure diameter of left main around the 5 mm and mid CX 6.2 mm. So in conclusion, the Medina 01 lesion is the present unit challenge with regard to osteomyelitis and main vessel protrusion and the potential for the main vessel injury and compromise. Medical management should slightly retain its position of the primary as present. And we have to follow in the education present, consider DAB as the primary treatment strategy. And if the stents must be performed, the most appropriate stent strategy is the evented personal crossover technique as well. Thank you for attention.
Yeah, thank you very much for your presentation. Very excellent presentation, actually. And I would like to hear from the panel and faculty. So let's start with the Dr. Duy Phương from Vietnam. Could give some comment about this case?
Thank you. This is a very challenging case, but the concrete reason is that L6 is sure, but it's the big is.
Yes.
And before used to use the DCB in the proximal CX, But why you don't use in DCB in the middle?
Yeah, good questions. Because at that time we cannot put the bigger balloon, NC balloon into the mid CX. So that's why I just use the 1.5 and then the 2.5 very tortoise. And then we try to put the bigger, because at that time we in the store we just the DCB 2.5. So we cannot put the bigger balloon. So that's why just the Boba in the mix CX.
May I have questions? I do agree that you want to keep it as simple as possible, but in this case, why didn't you use another guide wire to the LED? Because when you dilate the circumflex, it may cause the plug shift to the LEDs. I think it is very important to put the guide wire to the LED, and it is also important to use the iverse to investigate the whole vessel to see if you do need to do something with the LED as well. That is my comment.
Okay. Thank you. We're thinking about the iverse, but you see in my cat lab, the iverse, the tip is very, very big. So you see just the 2.0 balloon, we cannot roast the balloon first. We do a lot of the support, the guiding as well, and 2Y, double Y. So that's why we cannot use the iverse.
I agree, Dr. Ling. Not IVERT is the circumflex, IVERT to left main LD, IVERT to distal of left main. Because you will predilate the atrium of circumflex, yes, we have to predilate with scoring balloon, the cutting balloon. We could tuck on the distal of left main. It's a chunk of left main bifurcation. So we need to check the IVERT of the distal left main and atrium of LED before you predilate the atrium of circumflex, and you put the DCB in the circumflex and let the distal left main and LED leave alone. So because after we talk on the atrium of the circumflex, you make to every chain is a chunk of bifurcation of left main. So it's a very dangerous for patient if you don't know how something after that. So that's why we need to check efforts, not circumflex.
Yeah. Thanks. That's very nice case, elegantly performed. I think DCB was a great option here, and that algorithm was very interesting. How to approach an isolated side branch stenosis. But I can see that's from 2005. It's a very nice recent development with this kind of circumflex. I don't know if anybody in the panels with live IVERS guided scan positioning. And I haven't done it myself. I think that Scott Harding and others from New Zealand have been promoting it. I don't know if anybody in the panel's got experience. Ishihara, have you tried doing hospital circumflex stenting with IVERS in the left main LED, or guys from the panel from Hong Kong, anybody? Frankie, you got some experience? If you want to share with us how to do this. Alan? I think it's really useful technique. Oh.
Okay, I think this is emerging technology nowadays. I think pretty much it depends on the angle of the bifurcation, right? If you have a narrow angle, probably most of the techniques still have one of the stand will protruding out in the main branch. Perfectly, if it's close to 90 degrees, I think nowadays, I think if you have the technology, you need to 7 French. Put a not all the IVERS catheters can No. It's just one 7 French. 1 7 French, and then commercial available Boston IVERS is able to compatible. If you're in Japan, we have used the Terumo other wheel as well, but not for Volcano, not for the big one. You need to fit in the IVERS to the main branch, for example, in this case, LED, and then put the stand in the side branch. You need to have the in and out motion to check the real exact position of your stand. If you see the classical paper by Scott Harding groups, actually you can differentiate the stand together with the shaft. And then while you are putting in and out of the bifurcation, you can see the exact location of the ostium. And then actually, in our experience, if you are practicing more without any contrast, you can able to put in stand. But all at the end of the day, it depends on the angle of the bifurcation, right? If you have a narrow angle, then it's another beast. So either you miss the ostium or you need to protruding something like a tab.
So what is your criteria for that, for the IVERS? Like you have the clear criteria for the use of IVUS in order to position the stent at the atrium of the like aortic atrium. So
yes, nowadays we are trying to collecting more data and real cases with big series. So I think it's much better than our best cases use is the osteo LAD.
So one more question for you that actually very interesting. I and Raj already discussed about that. So how do you stabilize the system in order to position the stent, because it's quite moving, because the left man have the one guiding, the big guiding or two guiding catheter together. In case we use the smaller guiding and we have to use the second one, and if we use the bigger one, so how to stabilize that in order to make the strong backup and then strong.
You mean the aorta also, right?
Yeah.
Yeah. So when you put in the wire in the cups, right, the IVUS there usually will make the movement less already. Unlike you just put in two wires, one in the LAD and one in the cups, right? Because you're putting extra gear to your 7-French guide. So it's already a little bit jerky and it's not that easy to manipulate. So that will help to stabilize the stand. So of course, another point is choose the, as mentioned by the speakers, right, choose right stand is also very important. Not all stand land at the marker. So when we see from the IVUS exactly, sometimes for some stand, the balloon marker and the end of the stand can be visualized. For certain stand, actually both are at the same position. So we just focus on the image of the stand through the IVUS. Then we can clearly position. So it takes time, no hurry, and then you don't need to inject contrast to see. So make sure you are right there. And from our experience, most of the time, even the also it didn't really jerky a lot, in and out.
Yes, thank you very much. And how about the precisely position at the atrium of the vessel, Doctor? I would like to ask Dr. Brian and Dr. Wei Chun Hwan about the position at the atrium of the lesion like 001. Instead of we have crossover, or we took a hanging stent cell at the POC. So do you think that precisely is the best option for the lesion like 001, or you just crossover is easier? So what is your experience in this?
But I think if we put stent, sometimes stent easy to induce instant restenosis. I think Dr. Hughes' idea is very excellent. We can use DEB and we can reduce instant restenosis. So in my opinion, usually I would still favor use DCB for the 001 lesion in these cases. Thank you.
Brian, do you, yes, Brian, yeah, you use the precisely position, or you just the crossover or hanging the stand at the BOC? Because has a study came out about, I think almost 10 years already, they just hang the stand cell at the BOC, and then it's easy to cover the whole atrium of the bifurcation. Is because sometimes we're not easy to position directly at the atrium of the vessel, because the angulation cannot give us a good position.
I think you're right. I think if you can, theoretically, if you can get it right at ostium, great. But often it's because of the angulation, patient movement, a lot of movement, and then you may end up missing. So you have to balance whether what's the downside if you actually miss it, if it coming extension too much, and then you end up finding what's probably easier than to do it the crossover if you can. If you can, actually, the patient is very stable. Angulation is it's almost perpendicular. You actually hit it the ostium. When like with Al says using IVUS imaging very precisely, great, but it's not always possible. So then you have to say in that situation, maybe it's probably better off doing something a bit more complicated.
Yes, we got I think 2 comments from the audience.
Okay, thank you for your case. It's very good experience, but I just think worried about our patient, because you see circumflex used with NC balloon, colorless. So I think the best way here, I totally agree with Dr. Cha Yang. We should do IVUS to make sure everything's good in the ostium circumflex, also distal left main. After that, I think in this case, we should go directly ahead to stenting, because I cannot live alone with the proximal of circumflex. Also, ostium circumflex is very dangerous for the patient. you see after use wiring some not good. So I think we go ahead with stand-in, which is techniques, tap techniques. After that, we make sure which IBUT again. I think it's good for the patient. No need to leave the patient look like it. It's not good for the patient. Okay,
Thank you.
This is my comment.
I think DCB in the setting is still an evolving indication. I think it's a journey. So we're all, Dr. Lam.
Yeah, I just want to make a very short comment regarding the precise stand length. Be careful of stand elongation after post-stand high pressure. I can tell you this is true and very real. You get very precise landing, but after post-stand high pressure, the stand will elongate and protrude out. And need to be careful of that. Some stands are more vulnerable for stand elongation, some are not. You need to be very careful on this issue.
Yeah, thank you very much. I think time constraint, because of time constraint, so we still have many questions still remain for the speakers to answer, but the time is not enough for that in order to discuss. So we have gone through the, I think, the very excellent presentation so far. So now we have to put it up for the next presentation, next section. So thank you very much. Thank you, panel, and thank you, the chair.